Not on time. Welcome to the 37th meeting in public. Everybody's doing nostalgia down here about Doctor Who, and it's 40 years since I qualified this year. So I'm going back to the smoke and grime of Leeds, which I understand isn't smoky and grimy anymore after 40 years. Welcome. I'm Graham Lewis. I'm chairing this meeting. I will keep us to time. There are no fire drills expected, so try and keep up with me as I leap through one of the exits if the fire alarm does go off. If you have got mobile phones and pagers and don't want to be embarrassed by them, you might want to set them to stun. I know there are a few people around the table who are on call and have other duties, but if it's quiet, that would be helpful. I will keep us to time. I do have another spiel to read out, so welcome to our governing meeting in public. In relation to questions from the public, the CCG is committed to openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. Although the meeting is held in public, it is not a public meeting. This means there is no opportunity for the public to ask questions apart from that offered at the Chair's discretion. There is, as members who've been here before aware, there's a specific time slot at the end of the agenda. The governing body meeting is also being videoed, as we were last time, as part of the commitment to make information as accessible as possible. I encourage members who want to know what their particular habits are to watch. It's quite an edifying education. The video is going to be put on the website within a few days, and the CCG does not allow any other recording of the governing body unless previously agreed with the Chair, and nobody has. And we have a protocol saying how we will conduct our meetings, and this is available on our website. So that's the longest welcome I've done in a long time. So welcome and introduction. So I'd like to welcome Catherine, thank you, who is our new board member and our nurse member. Can I also say thank you to Fergus, who had been standing instead for the last few meetings. So thank you for the job you did, and welcome to Catherine, who's also the nurse member on Kingston as well, so brings a wealth of experience. Perhaps you'd like to give us a brief intro, and then we'll go around and introduce everybody so you know who's who.
Thank you. Very briefly, so I'm a registered nurse, health visitor and nurse teacher. I'm currently, as of March this year, I went to the London-wide LMC as the Director of Primary Care Nursing, Workforce Transformation and Innovation. I lecture now at the RSM as well, and before that I was the National Professional Lead for Primary Community and Integrated Care at the RCN. I'm a Kingston CEPN member as well, and I do a varying range of other things. Thank you very much. Catherine Yates, member.
Swin. Yes. Shannon Coutinho, consultant in public health.
Fergus Keegan, local director of quality.
Nalini Roberts, local director of finance.
Julia Travers, local director of commissioning.
Cathy Sheldon from Richmond Health Watch, standing in for Don Thompson.
Graham Lewis, GP Chair.
Sarah Blower, Accountable Officer. Can I ask people to actually push the buttons because it's for the filming as well? Thank you.
Kate Moore, GP and Vice Clinical Chair.
Jo Dandridge, Governance and Business Lead.
Bob Armitage, lay member.
Susan Smith, lay member.
And Dawn Hall, secondary care consultant.
Push my button as well. So any new conflicts of interest before we move on, other than those that have...
Hospital, if it's relevant to anything.
Any other changes or new conflicts of interest? Okay, let's move on to the minutes of the 36th meeting. So, which is page 7 of the 157 pages of the first bundle. So, page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 13. Any matters of accuracy? Any comments? If there are none, thank you, Joe, for the back office work again. Action log. There is no action log, as people will have noticed. I'm assured all the actions have been completed, and it has been suggested that if that's the case, we bring an action log anyway, just to show what was done from an audit trail point of view, which I think would be helpful for next meeting. We are now on item 1.4. We'll say which item we're on, because often the committee is ahead of me and will keep me on track. So items taken in private at the 4th of September meeting was the proposal for a governing body for collaborative decision-making committee across South West London. That was in fact approved, and we've had a meeting of the collaborative committee, I think, since then. And we also had an update on our financial recovery plan, which we are constantly updating and renewing. So if I move us on to my Chair's report, other than welcoming our new governing body member, I think everything else is pretty much covered in the Accountable Officers and Managing Directors report, so I'm going to move on to the Accountable Officers report.
Thank you very much, Chair. So firstly, I've had a lovely holiday. Thank you very much. So I've been on holiday for a couple of weeks. So I have missed some of the things that have been happening both locally and across South West London, London and nationally. But just to give you a bit of an update, I did go to a national meeting about the development of strategic partnerships, or our health and care plans as we call them in South West London, and our health and care partnership, and how we look at integrating services going forwards on Tuesday. And it was very positive, but what it said to me was that in the new planning that's coming down nationally, which we expect to see very soon, probably before we meet again, the focus on the local integration and health and care plans and how we work with our local authorities, our providers, and in an integrated way across the whole of the NHS and social care is going to be really important for how we take forward our planning into next year. And actually, I think we're in the right place in South West London around some of the work that we're doing with our partners to actually start to take the step forward into the future. So I thought that was very positive. And we talked a lot about how we build both integrated partnerships at a local level, but also across organisations on a larger geography. And we've done, as we know, quite a lot of that work as well across South West London. So I think we're in a good place to move forward into the future. We're expecting some planning guidance to come by Christmas, and we are expecting the new 10-year plan, or the forward view, to come to us from the national team around the end of November, beginning of December. As soon as we receive that, we'll make sure that that's publicised to our public, but also to governing body members. And I'm sure we'll have future discussions on that and how that impacts on us.
Thank you very much. Any questions for Sarah? If there are none, then I'm going to move us on to item 1.7, the Managing Director's report.
Thank you, Chair. And just a few items to update the governing body members on this time. Sarah talked about the health and care plan, and Julia Travers, our Director of Commission, is going to give an update of progress for the Richmond Health and Care Plan later on the agenda. But just to highlight to governing body, we do have an engagement event on the 19th of November, and that's part of our wider engagement. And it's going to be held at the Twickenham Stadium, and it's going to be opened and chaired by Councillor Piers Allen, who is the Chair of the Health and Wellbeing Board. And it's for around about 180 people from 3 groups. So we're bringing together health and care staff, local people and representatives from different community organisations. So following this, we'll use the outputs of the event to further shape our health and care plan. Over-the-counter medicines, at my last report, I described the latest position regarding over-the-counter medicines. Since then, we've been working on the communication materials for GP pharmacists
NHS trusts and other partners, and that will be available and launched this autumn. And it will coincide with our winter messages about patients going to the pharmacy at the first sign of illness and keeping a stocked medicine cabinet at home. So it all links into that self-care, self-help prevention piece that we are promoting in Richmond. And also, I think yesterday, Secretary of State was talking about prevention and self-help and self-care. We also launched in October our outpatient transformation project. That's NHS organisations across Richmond and Kingston working in collaboration to transform outpatient services so patients and GPs can access the advice and services of specialist clinicians in the most efficient and effective way. I had the pleasure of opening that event with Anne Radmore, Chief Executive of Kingston Hospital, and the event started to discuss what this transformation could look like, and also to how we involve linking appointments together to reduce number of hospital visits for some patients. So look forward to seeing the outputs of that piece of work in a future governing body and engagement events with our population. We had a very successful AGM in mid-September. Thank you for everyone who attended, and also thank you to the young people who talked about the piece of work they've been doing. They were looked after children who had been doing some artwork and art therapy, which was really powerful. So I'd like to thank them for coming. Our community provider, Hounslow and Richmond Community Health Care Trust, have had a successful couple of months. They've had a CQC, which rated them as good for safe, effective, caring, responsive and well-led, and that's really good. I congratulate HRCH on receiving that CQC rating. They also won a Nursing Times Award for the best place to work for employee satisfaction at Community Nursing Trust, and 90% of the staff felt the trust takes a positive action on health and well-being. And I think that's fantastic news for us, that actually we have got not only a high-performing CQC-rated community trust, but actually staff who want to work in that trust. And that's really good. And finally, I'd like to introduce David Stouts, who's sitting in the audience. He's our new Interim Director of Transformation. He's coming to work with us in Richmond for 6 months to really develop our clinical model and our transformation programme for the coming years that aligns to the messaging and the priorities that will be in the 10-year forward view. So welcome, David. I'm sure a lot of you will get a chance to work with him and chat with him over the next couple of months. So that was all from me, but happy to take any questions.
Thank you, Tonya. Any questions or comments for Tonya? Okay, moving us on then to item 1.8, South West London Health and Care Partnership report from Sarah.
So this is the second time we've brought the report in this format, and we've done a little bit of a deep dive on some areas again, so you can see what's going on. I would just pull a few things out of this report. Firstly, Tonya's already talked about the local health and care plans. These are a really important part of how we develop our plan going through into next year. We know that we're going to have a South West London plan renewed for the summer next year. We're already on that journey in South West London, and we're building our South West London plan on the local plans that are being developed in each borough. So the local health and care plans are a key part of what we are trying to do across South West London, and particularly important in Richmond, as we know, because we have financial challenges, and part of us transforming services means that we can make them as efficient as possible. So really good to see that work going on locally. I'm going to also draw your attention to the children and young people's mental health work. We identified this as a priority in South West London long before the national priority was developed, and we've done a huge amount of work across South West London to develop a plan that focuses on support for children, support for teachers and support for parents. And we want to roll that out across the whole of South West London. So we have bid for funding for some of our boroughs based on an invitation to tender by the national team. But regardless of what happens with that, we have made an agreement across South West London to roll this work out across the whole of the 6 boroughs. And we're really looking forward to working with our partners to make sure that we can provide the absolute best start for our young people in South West London. And I also wanted to just bring your attention to the final part, the final item on there, which was around workforce. We also committed together to making South West London a great place to work. We all know that it's a fantastic place to work and that we love working here, but we want to encourage others to come and work in South West London. We want to make sure that we retain the staff that we have. So there's a lot of work going on across South West London to say, yes, individual organisations do work in a certain way to retain staff, but actually there's more we could do together. And one of those things is around making sure that we make absolute best use of things like the apprenticeship levy. So we have got a South West London Academy that we are setting up so that we can make the absolute best use of that and gain more apprenticeships. We are looking at things like a passport, which means that no matter which provider you work in South West London, if you've done your mandatory training, you don't have to redo it if you go and work in, say, Epsom St Helier when you've done it in Kingston. So, you know, and we will trust each other. So there will be a passport for staff. And we're looking at whether or not we can do training packages together. We're looking at a whole range of things that we can do together in order to support staff and ensure that we retain staff in South West London. So I thought it was probably those were the things I was going to bring to your attention. There is also additional information in here about other work streams.
So any questions or queries from Sarah on that report? Sorry, Catherine. Sue, can I ask you just to turn off your mic? Oh, is there a glitch?
Malfunction that it won't go off, so we'll try not to breathe.
Thank you. Sarah, I was just going to respond back around the passport as to whether or not we can make sure really that we've got currency there for primary care nursing in particular and for staff working in primary care. Sometimes secondary care can almost sort of sometimes overtake, and there are some very distinct differences. So I think it'd just be useful to ensure that we've got a strong primary care voice there when we're looking at developing tools, particularly around the workforce piece.
Yes, I think that's a very fair challenge. What I'll do is I'll take that back to the team, make sure that they are picking up. They are looking system-wide. It is actually easier, as we know, to do it in, you know, in a small number of acute trusts. It's much more complex in primary care, but I think there is a lot more we could be doing. So I'll take that away and make sure that we are picking those areas up.
Okay. I only knew I was coming here last night, so I haven't read any of the papers in advance. But I'm pleased to see you're prioritising children and young people's mental health. In recent months, I've had several members of the public, including a local councillor, approach me about the drastic shortage of support for children with mental health problems, particularly those in their teens. There's nowhere for them to go between seeing mental health teams and so forth, nowhere for parents to get support, and they need some sort of crisis care drop-in centre or something. And I'm told there's nothing in Richmond. I don't know much about the children's sector, but I don't believe it's adequate, and people are crying out for support and help.
I'll ask Stavroula to come back on the specifics around Richmond. What I would say is we absolutely recognise children, young people, mental health is an area that we want to focus on. It's for the future. We do, it might not be it might not be a drop-in centre, but what we need to do is make sure we've got the right way of working with the voluntary sector, with schools, with parents, in order to deliver something that's really robust to support people. I'll let Stavroula talk about maybe some specifics around Richmond.
First of all, I welcome, of course, this focus on children and young people, and I think it's great that work is going on at the root of where children really spend most of the time, which is at school and at their parents' homes. So I think that's amazing. Of course, we have got children, young people, mental health services here, and just like anywhere in the country, there are always areas that are not completely covered. There are very good services for children who are very unwell, but I think we need to do more at these roots of children's well-being.
This is very much about keeping young people well. This is about preventing them from getting very sick and making sure that they can access some services when they do. So what we have in South West London is we have a significant number of young people self-harming. We have a significant number of young people needing to access some support that may not be actually health services. It may be that they need some support in the home or in the school. And this is about trying to bring all of those things together in a different way. So we will roll it out in Richmond, and it is part of a national piece of work now, but it is something that we identified early in South West London. So I think we all are really happy to take this forward.
And perhaps if there could be some mapping so we know where support is available.
One of the parts of the programme is around a directory of services that will be accessible by also, there will be teams of people working with schools, with parents and with the students and with the children and young people themselves, but also they will be linking into a whole directory of services around voluntary sector, health services, social care support, working with families as well. So all of that will be part of this process. So it focuses on a number of different areas.
Can I also refer you to, we've just refreshed the CAMS Children and Adolescent Mental Health Transformation Plan, and that's on the Health and Wellbeing Board's agenda next week on the 13th of November. So we've just been working on that document for Richmond. So one of the things I will go back and take back is whether or not we are covering that adequately. But equally, that is the document that's now summarising everything that we will be doing for children and young people with mental health problems across the borough. So that's a recently refreshed document.
I just to ask, it was on the media that the Department of Government has promised some extra 2 billion funding for the mental health for teenagers. Is this money that will be coming in?
So what they're doing nationally is they have asked for bids for trailblazers nationally for the first wave of doing some of this work. We have put a bid in. They asked us only to put a bid in certain boroughs because you had to meet performance requirements. So we put in for 3 boroughs in South West London, which was Sutton, Merton and Wandsworth. Which were the 3 that we were asked to. But what we have done is, because we were already doing this work across South West London, we have said, regardless of when the national funding comes down, or if we are part of the Trailblazer, we will do this across South West London. So we've committed to that through our finance committees, and we'll be taking the work forwards. But that is the central funding will come down firstly through the Trailblazers, and then the intention is to roll it out to everyone nationally. But it will take a number of years, I think, for it to fully roll out.
I haven't broken the system, so I'm going to move us on, sorry, to item 2.1, elective activity oversight, and that's got your name by it, Yarlini?
Yes, thank you very much. So the report that you have with you is the South West London elective activity oversight report, but I'll just concentrate specifically, obviously, on Richmond, if I may. As part of the operating plan this year, there is an expectation that the total waiting list, or patient tracking list, PTL, is maintained to at least the March 2018 levels. Now, as you may be aware, there has been an increase in the total RTT PTL, patient tracking list, and this, unfortunately, has been seen nationally with actually quite a distinct increase in London. What I am pleased to say, though, is that in Richmond CCG and predominantly working with Kingston Hospital, we have maintained the standard of 92% of people being seen within 18 weeks of referral. However, there has been an increase in the PTL, which you can see on slide 4. So the purpose of this paper is to inform the governing body of the increase that we are seeing and the range of actions that are being taken. So if I can take you to the very red slide, slide 4, you can see that in Richmond, between the 31st of March this year and the 31st of August, there has been an increase of about 23% at Richmond CCG. And in terms of the increase at Kingston Hospital, that's a 21% increase. Now, a lot of work's been taken to understand the increase in the waiting list. We are working with Richmond GPs, and you will see that actually on slide 2, the performance there, where actually the referrals that we are seeing from our Richmond practitioners are decreasing. So we're looking to work with Kingston Hospital to understand the action plans that they've got in place. They're working to bring back the trajectory to by the 31st of March to those levels. We are confident, though, actually, with Kingston's data. So what we are assured of is that they have a robust operating PTL, and they've got visibility of all the patients that they are seeing, and they are ensuring a chronological booking system. We are working with them in terms of getting the work plan from them, and actually Fergus and his team are instrumental in looking at that. And I think the other positive that we have for our Richmond practices is that through our primary care leads, we are effectively looking at demand management. So I was going to stop there and take questions if anybody has them.
Thank you, Yalini. Any questions or comments? Kate?
Do we have, I mean, do we have the data in more detail, so things like by specialty?
Yes, we do. So we do have, and what we're going to do, actually, Kate, is we're going to bring a detailed report to the quality committee, because I think actually that's the area to do. Because actually what's quite interesting is, specifically for Richmond, there is no real correlation between some of the waiting lists and the specialties. So, but I think we'll have that more detailed conversation in our
because I think as clinicians we'd be keen to sort of deep dive to be able to support how to work through it.
So we've done all of that work, and you'll be able.
You'll
to
share that with us.
Absolutely.
Thank you.
So I've got Stavridou and then Bob.
Yes, I agree with Kate. It'd be useful to have some of the deep dive, because I can see that Richmond is quite at odds with the rest of the CCGs in that it has reduced referral rates, which is, whilst that is great financially, we also need to make sure that we are referring appropriately when everyone else is rising. So it'd be useful to see that we're not tipping in the opposite direction, that we're referring as we should, really.
Just a quick question, Yalini. Was March a representative month? Because
it's one of those really tricksy questions, Bob. I suppose coming into it, I mean, what is a regular month? March is a heavy month that we see in other areas in terms of some of the non-elective because of winter and the like. In terms of some of the referral that we've seen, actually coming into it, we'd introduced kinesis. There was more patient-level information that was coming out of our BI areas. So actually, I think in terms of GPs acknowledging and in terms of information coming out, I think that gave a slight downward trajectory. But what I could do, and that's just a personal feeling, but what I could look at is trying to get the data prior to that to actually show the trends.
it might be helpful because clearly it might explain some of the jump.
Yeah.
So, and just to add, the March position was a convenient point in time, but any point would be a convenient point in time to take a national benchmark. So it's our closing position for the year end. So the position in terms of our ambition for the year end this year is the comparison to those 2 points in time. So that's what the expectation is, that there's no growth over and above what the year end position was.
So I learnt a new 3-letter acronym, PTL. Hadn't come across that one before. I think the debate has highlighted a few sort of data cliches. So first of all, if it looks odd, recount it. Don't trust the data. That's the first thing. If it continues to look odd, don't trust the analysis. Remember, when you're comparing two numbers, one is likely to be bigger than the other one. It doesn't necessarily mean anything. It's just you've thrown two things of the dice. And I think finally for the public, although this would indicate that there has been a reduction in referrals, this is a reduction in face-to-face referrals. We've actually started using other ways of communicating with consultants, such as kinesis, which is an email. So the activity, so it's not that we're preventing or stopping relevant patients getting relevant treatment. It's actually doing it in a more efficient and effective way. But we look forward to unravelling some of the oddities that are there. If there are no more comments, I'm going to move us on to item 2.2. Winter is coming, as the expression goes. So it's this Fergus.
Thank you, Chair. So this report provides the opportunity for the governing body to hear about some of the preparations that we've made for the winter period, and some of our plans in particular around how we'll communicate how the NHS is coping over the winter period. Thank you. I do apologise. I thought I had pressed it. We do see a busier period of time, so we are making plans to cope with an anticipated 10% growth in demand. We wish to achieve at least a 90% performance against the 4-hour waiting standard, and we want to continue reducing the length of stay for patients who are inpatients in hospital. We have made a number of improvements over the last year in our urgent and emergency care system, and I've listed those out on the next slide. This includes some of the things that we felt would have the most impact. So our 7-day frailty service for people coming into Kingston Hospital, the extension of our primary care access, which we've talked about a number of times before, and some very good progress that we have made around reducing length of stay and delayed transfers of care. We have a number of priorities that we have been working on over the course of the summer and will continue to focus on during the winter period. As I've mentioned length of stay. There are a number of what we call multi-agency discharge events that have been held over the year. And I guess really the summary of the outputs of that is that we need to very much focus on our pathways out of hospital. So this is about responsive and community and social services supporting patients when they are ready to go home. During the winter period, we will establish a Silver Command. So this is senior officers and partners from across Kingston and Richmond working with the Trust on a daily basis to manage on a day-to-day basis the activity and the flow within the hospital and pathways out of the hospital. And I think really some of our evidence of that working well over the course of the year has been our significant reductions in delayed transfers of care and length of stay. The second part of the slide just talks a little bit more about our communications and engagement strategy over the winter period. So we are working in partnership not just with NHS partners, but also the local authority, the voluntary sector and Health Watch over the coming period. And our campaigns are very much focused on things which we have talked about earlier in Tonia's report about prevention, self-care, and indeed about redirecting patients to the most appropriate services. Our campaigns will align with the national campaigns, and some of these you will already have seen, whether you are watching the television or radio or indeed social media. So a focus on the winter period, a focus on looking after your neighbours, pharmacy and use of pharmacists, but also looking to direct people towards NHS 111, which is an excellent resource for helping people either to identify ways that they can support their self-care management, but also they can offer appointments in primary care, offer appointments in urgent treatment centres and the like. So we'll do this through a range of mechanisms. As you can imagine, we'll make the most of our social media and other channels, but again, I think the partnership approach using the channels that the local authority have and the opportunities for face-to-face conversations with the general public. And in this year, we're looking for greater direct engagement with staff. We know we have over 100 staff employed in the CCG, and every time our members of staff are out and about in the local community, we'd want to remind them of the importance of things like the uptake of the flu vaccine and preparations for extremely cold weather periods. The A&E Delivery Board reviewed the communications plan at its last meeting in October, and there were two particular areas that we identified we would like to see a focus on in the Richmond area. So specifically looking at children under the age of 5, but also adults over the age of 75. We will look to focus our communications with those specific groups, particularly around issues such as flu vaccination, as I've mentioned already, the use of pharmacists. We'll continue to promote the excellent paediatric service that we have at the Teddington Urgent Treatment Centre, and again continue to promote the extended hours GP service. We already know that we hit into the high 80s and 90% utilisation of those, and we need to make sure that we keep those numbers up over the winter period. And finally, again, our partnership with the local authority on some of those softer things that people don't often think about as a role for us in preparations for winter. So things like gritting pathways and roads, winter fuel grants for the population to make sure they keep their houses warm, and over the Christmas and New Year period, activities such as healthy drinking. So I'm happy to take any questions.
Any questions? Did you want to add anything, Branko, about the services over the winter? Or
I think the A&E Delivery Board is really working very hard on achieving all those aims. I think that there is very focused work, especially that is happening now at Kingston Hospital and also with our community providers in Kingston and Richmond as well. I think we are quite happy that we work very well with our colleagues at Kingston CCG, Kingston Hospital, and all our providers on both sides of the borough. So preparing for the winter, I think we are quite well prepared.
Okay. Any other? Yes.
Just wanted to check whether anyone has considered the new NICE guidance on increasing uptake for flu vaccinations, which was published in August this year, whether the comms and engagement team are looking at that.
So we are taking us out. Mine's not working at all now. Yeah, thank you. So the comms and engagement that we're doing it very locally focused on things like working with our boroughs and voluntary sector, but we're trying to take an approach around the priorities across South West London. So things like flu vaccination, we are looking at the uptake, and we're working because we now have specialised teams in South West London on communications engagement. We have social media teams, and what we're doing is so if someone kind of goes on their Facebook and they start to say look something up, they'll a medical thing, it will pop up immediately with things like their nearest urgent treatment centres, how they can access their GP out of hours, and we're trying to do the same thing around flu vaccinations as well, and we're trying to target those groups that need to have a flu vaccination, so around young children, those that are at risk and older people and so on. So we are taking a much more focused approach to how we do our comms and engagement now, because I think what we've learned is that, sticking an advert on the side of the buses looks all very well and good, but doesn't actually maybe achieve the results resource that we need. So we're looking very much more now at very targeted communications and engagement, how we hit social media, how we work in a very different way, and that's why we're talking to people face-to-face direct contact. We know that staff talking to individuals is a way through getting some of the messages across. So we're having a lot of that discussion across South West London, and it's feeding into the local plans. So the local plans are very locally focused, but they are with the support of the South West London team and what we're doing at South West London level.
Just a couple of questions / comments, basically, because I can see a lot of the work is very focused. Two questions that I had in terms of reducing pressures, because you mentioned the children under 5 and the over 75s. Has there been any thought or any discussion as to whether, within the hubs that we've got, whether some of the appointments can be reserved for under 5s only or children only to relent some of the pressure that obviously in the winter months that children would put on the services? And also, one thing with the elderly patients who get admitted as well, one of the difficulties that we found is getting hold of community IV antibiotic services is actually quite difficult. And having gone through a number of admissions, it's apparent that it could have stopped a few admissions for us specifically for our practice. I'm just thinking if that's scaled up, if there's easy access to community IV antibiotics, could that be a relatively quick win in terms of reducing admissions?
So in terms of reservation of slots, I think we have talked about that on a number of occasions, and I think it's a really difficult one to balance, because actually during Monday to Saturday we're already at a very high utilisation rate of our slots. I think part of our strategy, as I've mentioned, is about channeling patients and parents, or children and parents, to the excellent paediatric service. I think we've got more capacity, more opportunity for providing dedicated slots for them. In terms of the community IV antibiotic service, that's the first time I've heard that there have been some challenges around accessing that, but I can certainly take that away and look at, in partnership with HRCH and on the Kingston side, Your Healthcare, about whether there's an opportunity to increase that. But I'll certainly take that away.
Just one quick thing. Just have a look at the HRCH referral form. It's not very easy to use. It's quite challenging to get it set up, I find.
I'm pleased that you have Health Watch involved in this. Could you perhaps also engage with some of the voluntary sector, particularly the neighbourhood care schemes, who can provide things like transport and visitors to people, particularly older people, and also perhaps generally all the staff in the CCG or who visit patients should know more about the food banks, where they're at, who can access them, and help people, particularly older people, and it might be families with young children, to know exactly where they are, how they can access, and what they, if they're qualified to access them.
We actually, there's an ability to get, I think, the vouchers in the practice. So as part of the social prescribing signposting, one of our members of staff had access to it and certainly raised it within the practice. So I know that the practices can hold the vouchers, which is helpful, and refer patients.
Thank you, Kate. And just to add, we do have a meeting later on in November for the 5 local Health Watch chairs to receive the winter report and to talk through the contents. So that, I think it's the 22nd of November that meeting is happening. It's a regular meeting, and that we've taken the opportunity to focus principally upon winter and winter preparations, and that will include Kingston, Richmond, Wandsworth, Merton and Sutton Health Watch chairs.
Thank you. I was just going to raise a point around, particularly around the extended roles of district community nursing in particular, who provide often or not IV antibiotic therapy at home. And I'd like to kind of know, I know it's variable nationally, so I'd just be interested to know really what our spread is, particularly across Hounslow and Richmond community healthcare. And the second point was around care homes and around the need to sort of ensure that residents within care homes are well attended to in relation to obviously deterioration, particularly around issues around dehydration at this time of the year. and that actually there's maybe, for me, I'd like to see a little more there around kind of how we're going to engage with care homes in particular, because obviously referrals in at that time do sometimes spike.
Branko?
Just offer maybe some of the questions, not all. Regarding the community IV antibiotics, this project has been going on at Richmond for many years. At one point there was a nurse, and that nurse went somewhere else. Now that nurse, is, as far as I know, is not in the community. There is no trained nurse. So intention was of CCG to ask our community provider to have the service that is going to provide IV antibiotics in community that is going to be functional. So what exactly is happening, I think we need to liaise with the HRCH. Now regarding your questions about the pediatrics, I just remind all the GPs that are here, and also maybe wider GP community, we need to use we've got 4 very specialized independent pediatric nurses that are providing pediatric service at Teddington Urgent Treatment Centre, and this is number of the appointments during the day. Not only when the surgeries are closed, they're open during the day for all the emergencies. So this is a great new service with great scope. So make sure that we are not underutilizing. There are many things in communities that are not mentioned in that report. Okay, we got out of our service that is working. We got the community services. We got triple R rapid response team that is working. We got community nurses. We got Nightingale. So there's a whole bunch of services that are providing care, and also they're going to speed up in a winter time. So I think we are quite ready. The only thing is that IV antibiotics. What is there any need, and what is the need? Probably it is up to us, the commissioners, to decide.
Okay, perfect. So the kind of challenges I found with using the community antibiotic service is that there's a question on it saying that the prescriber agrees to be available 24 hours if there's any questions or concerns or complications of IV antibiotics, which means that pretty much no GP can use it or be willing to use it when they see that. And also, I think it'll be quite useful to have antibiotic guidelines in terms of IV antibiotics for various conditions on that form, because obviously we don't work with IV prescriptions that often, so it's quite challenging and quite hard to find the confidence to prescribe something IV when you haven't done it for a while.
Okay, I think we need to take that outside the meeting, and we'll come back to that. Any other comments? The 10% figure, is that because it went up 10% last year, or is there a rationale behind that?
So I think it's prudent to plan for that figure. If it's less than that, then that would be fantastic. We have had less than that in terms of a percentage growth this year, but based on last year and the year before, there's an expectation that there will be that level of activity. And again, a lot of the focus is about managing that demand in some way, because very often some of that growth is people who could have access to other services, so pharmacy services and the like. I just wanted to mention one other thing, coming back to Catherine, around care homes. So we do have a programme of work that we are commencing over the winter period of additional and enhanced nursing support into a number of care homes, those with the largest volumes of patients and those with the highest out-of-hours or A&E usage. And we're very actively promoting, in terms of our communication strategy, the direct access for professionals in nursing and care homes to contact 111 direct. In effect, there's a bypass route so that they can speak professional to professional about concerns about a patient. So that clearly is part of the programme of work this winter.
Any other comments? So I think there's a strategic theme underlying this, which I pick up all the time, that we could do better in Richmond. We could do better with children. We could do better with complex elderly and adults. And we could do better with communication, and that would take an awful lot of heat out of our system. Those are my 3 C acronyms for today. Anybody watching on YouTube, as long as it's not next March, it's never too late to have a flu jab if you haven't already had one this winter. So I'm sure our public health people will be telling us all about that as well. I'm going to move us on then to Richmond Health and Care Plan. Is that you, Julia?
Thank you, Chair. This morning I'm going to provide an update to the Board on the development and production of the local health and care plans. plan that I'm doing in conjunction with the council, the voluntary sector and local people in Richmond, apologies, and the alignment of the CCG's commissioning intentions for 1920 against the plan. And what we will be seeing over time, and if you were to reflect on it, also looking at the CAMS transformation plan, actually the themes are all there, and the strands and the linkages between the local health and care plan, commissioning intentions and the other plans that we are producing. So we've got a consistent picture. The local health and care plans, if I can just take us back, is actually the description of our local vision and priorities and actions to meet the local health and care of the local population in the London Borough of Richmond. And it's very much focused around those areas where health and care and the voluntary sector coming together will maximise the outcomes and the benefits for the local population. So it's not going to cover every aspect, because there are going to be areas which are unique to the council's business and unique to health's business, but actually it's where we best come together. And those are around areas, as we've heard about earlier on, around some of our children, young people, our older adults and some of our working age adults. The plan is built around all ages, and it's actually split down into 3 themes: start well, live well and age well. And within the plan you will see that there are the definitions for each of those areas. The plan is in development. It's an iterative process, and so some of the language is changing, some of the priorities are becoming more refined, and this is at a point in time. And I do apologise, but the date just in the plan that says we're going to the borough-wide event is the 21st. In this plan, actually, it is the 19th, and that's the correct date, and those who've been invited will hopefully have that correct date in their diary. So this is coming to the board as an update. So in terms of the plan itself, if I take us to the presentation piece, as a CCG, we are constantly working to continue to improve the services that we commission for our local population. And annually, there is a requirement on us to publish what our commissioning intentions are for the following year, which really gives notice, informs the local population, local providers of changes that we're intending to make to the services that we commission for them. And that may be along investments, it may be about transformation, such as we've heard around, flagged this morning about outpatient transformation, or it might be around quality improvements. The local health and care plan brings health and care together for the next 2 years in terms of delivering a joint plan, as I said, around those areas where best we will make the improvements. And what this is beginning to do is bring greater collaboration across partners. So the plan will be a 2-year plan covering 1920, 2021. Just a caveat on that, we do know the 10-year plan is due to be published just before Christmas, and we also know we need to produce a 5-year plan in response to that in the spring. So there is, or in summer rather. So there is something about how that all aligns, but the expectation would be that this would be our local component of that plan from the system. The plan itself, as well as our commissioning intentions, are built on insights from local people, so what local people have said to us and continue to inform us about the borough, what we know about local services, but also it's built on our joint strategic needs assessment and other information that we have available that tells us about the health and care and wellness and unwellness of our local population. And as I said, this is very much focuses on the London Borough of Richmond and our local population and those patients registered with the CCG. It's, as I said, it's built from what local people have told us and also reflects on the quality and performance of local providers. And you'll see on, sorry, the slides aren't numbered, I do apologise, the quality, performance and finance slide. Actually, we're very fortunate. We have Kingston Hospital, who's one of our main providers for some of our secondary care. It was overall rated as outstanding in aspects of its CQC report, and Chelsea and Westminster, which has other significant flows for our local population, equally was rated good. And you can see that they do well in terms of patient experience measures. The area which everyone challenges and is challenged by is the A&E standard of the 4-hour waiting time, and that as we know is national. And also we have the performance of the South West London St George's, and I would need to add in HRCH, our community provider, into this, as that's new information. And I think it's fair to say across health and care, one of our challenges is the demographic growth in the local population, the new technologies and treatments that are now available for local people. And actually it's juggling and targeting need and our spend against that. I'm not going to go into the key themes of the local strategies. We have discussed those, and they have been part of the local health and care plan presentations that have been made to health and wellbeing boards and to the board previously. What I have included is the local vision and approach for Richmond health and social care. And what I've done is I've gone back and reflected on the work that we developed in 2016, predates me, around the development of our outcomes-based approach to delivering a different offer to local people. And so what I've included in there are our vision at the time, and also the outcomes that were important and continue to be important for local people and their carers, reflecting those which were focused around community and physical health and those which were focused around mental health. And part of the work we're doing at the moment, of course, the health and care plan is not a mental health or a physical health plan. It is an all-age, all-condition plan. So, but if you look at the themes, they are very similar. So if we then move on to our commissioning intentions, as I said, they are our plans for next year. And what I've done on the first slide, and I do apologise if there is lots of information, but what I've shown on the first blue slide is that prevention is a theme that runs throughout all of the start well, live well, age well ways in which we are describing our local population. And in fact, the start well, live well, age well it should be very familiar to those of us who've worked in Richmond, because they have always been the way in which the local council, as part of Health and Wellbeing Board, and us as partners to that as health, have actually thought about and talked about our local population. And what I've done is I've reflected on key elements of the Joint Strategic Needs Assessment to say, what do we know about our local residents? And there are some stark facts in there about some of the mental health and well-being of our youngsters, the fact that we've got some very risky behaviours. There's information about our working age population and the estimated levels of anxiety and depression. I'm not going to go into all the detail, and of course this comes from the JSNA, and I've got lots of working papers which I've done in partnership working with Shannon from Public Health locally. And then there's some information about our older adults. And I mean, one of the stark one is that those aged over 65 who die in hospital were admitted to hospital on an average of 4 times in the last year of life. And later on today we've got the end of life care strategy, and we also saw in the AO's Accountable Officer's report the piece of work we're doing across South West London in terms of end of life care. So the themes that we're seeing in Richmond, some of them are reflected in South West London, but again are part of the work and our commissioning intentions. We've then got the priorities as they stand at the moment for the local health and care plan. As I said, those words are, the language and some of the wording for that are being refined and will be part, and the major part of discussions that we will be having at the event on the 19th of November. But this is an iteration moving on from where we previously discussed it as a board. And then there are some areas of impact outlined there, and that is not an exhaustive list. There are other areas that we could put in there. And then what the rest of the presentation does is then take the areas of start well, live well and age well, and aligns our commissioning intentions that came in draft in September to those areas. So you can see the themes, and you can see where we are looking at improving services, service developments across. And I'm going to assume that you've read those and you've looked at them. So then I really just want to flip you to the end of the presentation, where one of the key pieces of work linked to the development of the local health and care plan, and also our commissioning intentions, is the importance of ongoing engagement and partnership working. And so as part of developing the local health and care plan, there is a whole mechanism and structured approach to the communications and engagement with local people, most importantly, in terms of what our intents are around the local health and care plan, and also where we are and others. So that slide summarises the ongoing work, the work we've been undertaking, the ongoing work, the event on the 19th of November, to which many of you have been invited. And the intent then will be, we won't just do the plan and put it on the, sort of put it on the website, and there'll then be the ongoing engagement piece around demonstrating delivery of the plan and the impact and the success measures that we will be agreeing on the outcomes of the key deliverables, the key actions and activities and services that will align to the priorities. So flipping to the last slide, the next steps really very much focus on the work and the business around the commissioning intentions, whereby we are responding to, we've received responses from the providers with regards to our intentions, and we've received provider intentions which we are responding to. We're waiting the guidance that will come out from NHSI and NHSC around Christmas, which will provide us with further information as to the financial context and the commitments and requirements and the trajectories for next year. Where we are making service changes, we will be requiring to develop business cases. We will also have the long-term plan coming out, the 10-year plan, and we will move into negotiations with providers with regards to specifics around our commissioning intentions. So I think that's enough for now. It's a bit of a gamble through the paper, and I'd like to take any questions. Thank you.
Okay, so this was brought to us for information. Did you want to add from Public Health anything? Or
is that there's been a lot of focus on individual level prevention, and I think the recommendation is to try and see more place and community-based prevention in terms of the contribution of all the partners in providing a healthy environment, so not just what individuals can do for themselves, but what the environment can enable them to achieve. Thank you.
Okay, so this is an ongoing piece of work. Remind everybody there's virtually a whole day event on Monday the 19th. I will come back at the end. Any other comments? Kathy?
Do I need to mute this when you stop recording for this?
Yes. Just a reminder that 1 to 2 years ago, we were told that there was going to be a special look at primary care on the east side of the borough. There was a stakeholder meeting and there's been nothing since. Has this superseded? And if it has, can we please see something in the plan which says what facilities are going to be available for the east side of the borough, and that engagement happens with patients on the east side of the borough, please?
So can I leave you to take that away, Julia?
Yes, because I have seen the outputs and the work write-up of that event. And actually what we've been doing is we've, part of the delivery of the plan is around neighbourhoods, localities. And within the description of the work that was done around the east of the borough, it did describe what the local population felt was core. So I'm aware of that work and I've been reflecting on it.
Yes.
And so, yes, most definitely we'll pull that into what we're doing.
Can I just point out, though, that meeting we had was very much stakeholders who were clinicians and voluntary sector. It wasn't open to members of the public, so it wasn't actually public engagement.
Tanya, please.
Yeah, just to say that we actually do have extended hours now east of the borough in Sheen Lane. So that started this year. So we have equal access to 8 to 8 services on both sides of the borough. We also have the urgent treatment centre that is based at Queen Mary's that is used by the east side of the borough. And all the conversations that we've had to date with Wandsworth, who are the commissioners of services, that service will remain and continue. So in terms of equity, I think we are moving towards that. I mean, we will continue to review the services that we offer in primary care, but we have improved the offer east side of the borough.
Kate?
I mean, I think it is true to say that I think we're aware of, you know, all that engagement that took place. I think sometimes it's difficult because sometimes the drivers for change are difficult, and it's who we can influence, and that sometimes is quite difficult in terms of, you know, patients may have one view about things and how services delivered, but we may be, our hands may be tied in terms of contractually what we can do and, you know, the money and things like that. So sometimes it can be quite a difficult tightrope for us to walk in terms of primary care premises, because obviously all of our GPs are still deemed independent contractors. So it's, you know, what levers do we have to be able to, you know, support those things?
Yes, I think that's fair enough. But I think Health Watch would appreciate if there was some sort of statement saying how it's moved on, what is happening, and if this new care plan is going to be overtaking it and superseding it, and we'll see more through that. So it is about being honest and transparent with the public.
Catherine?
Thank you. I just wanted to raise a point around the prior, sorry, I think I need glasses now, the focus area with people with a learning disability, and particularly around the commissioning intention to increase the annual health check. I would kind of go further and say that it not just about increasing it, but actually making it meaningful and valuable, and actually that it actually has an impact that can be measured by those who are actually supporting those individuals, either to live independently or to live within a community. And then dropping that down around the engagement and partnership, it was around kind of particularly around engagement with organisations like MENCAP and others. And I just wanted to kind of ask for assurance, really, that kind of voice is going to be heard and enabled.
Thank you for that, Catherine. Yes, most definitely that voice will be heard. And I was in discussions with Nick Garland from Democratic Services at the Council, and they are in the process of setting up a deep dive. We will be undertaking a deep dive of services for people with learning disabilities and wider than that here in Richmond, and we're in the process of looking at who and how we form the task and finish group across a wide range of partners, and it would involve, most importantly, the voluntary groups, but also people with learning disabilities themselves. So that is work that is actually just about to start.
Okay, I am conscious of time, and I did warn people at the start that I would attempt to keep us to time, so I'm going to move us on unless there's something dramatic and urgent. It was heartening to see some of the work that had been done as far back as the OBC work that's been included, and I think it's important, as Cathy has alluded to, that we keep the organisational intelligence going. So that's, but I recognise this is a work in progress, and I look forward to seeing the next iteration. I'm going to move us onto the Board Assurance Framework, which is going to be presented by Tonya.
Thank you, Chair. Yes, unfortunately, Vicky can't be with us today. I wasn't going to go through the report line by line, you'd be pleased to know, and this is just an update. The only area that I was going to bring to the members' attention was the 3 very high-risk areas in our Board Assurance Framework, and they are PR4, failure to deliver the financial recovery plan implementation, PR3, which is a failure to deliver year-on-year QUIP targets, and PR48, which is a failure to fully identify the required QUIP savings for 18-19. But the report provides an overview of risks, control and assurances, and I don't think members will be surprised to know that they're our highest risks at the moment.
Thank you. Have there been any material changes in anything else since we last looked at this?
No, we review this in depth at every executive management team, so we will review again at our next meeting, but no, not materially.
Okay, does the board, I mean, it's a full framework here. Does any member of the board have any concerns they'd like to?
Yes, I know we're in financial recovery, and therefore, you know, the financial risks need to be at the top, but I think we also have significant risk around delivery of winter and A&E. I know it's on there on the risk register, I know it's on there on the Board Assurance Framework, but I wondered whether or not, just in our thinking about how we present this, actually, if we've got lots and lots of risks that are all rated as high on the Board Assurance Framework around the finances, then they're always going to be the top 3 risks. I just wondered if we could, in the Board Assurance Framework, consolidate some of those into the big financial risks, the big performance risks, and because then we get a bit of oversight across the whole governing body of the entire responsibility. Otherwise, it would appear that we were only worried about the money, which we are worried about the money, but we are also worried about other things as well.
I think that's absolutely take that recommendation on board. I suppose that how I'd like to assure the governing body is around some of our CQC recent visits have shown that we are still got high quality services, but absolutely specific risk around winter. We would obviously be very mindful of for the next 6 months or so. So yes, absolutely, we'll look to group them going forward.
Any other comments? Obviously, this is an important part of our governance structure, and obviously scrutinised in much more detail in other committees within the organisation. I'm going to move us forward then on to 3.1, Quality, Safety and Performance, South West London Performance Report. Fergus.
Thank you, Chair. So this report, broadly speaking, falls into two parts. There's a very local Richmond focus, and there is, at the back of the document, the wider South West London Performance Report. On the front cover sheet, you will see that I've summarised how Richmond performs against some of the very highlight constitutional standards, and as Sarah has pointed out, A&E and winter performance is a significant challenge for us, and it has been a significant challenge for this year to date. We've also heard from Yarlini's report some of the challenges around the 18-week referral to treatment performance, and whilst we've missed it for the month, we are still in a position of a year-to-date achievement for that. The other areas that I wanted to just draw the governing body's attention to was around, listed on the key issues. We've mentioned accident and emergency and referral to treatment, but also the consultant-led follow-up outpatient attendances being higher than planned. So the dashboard on page 4 gives you an overview of our latest actual and year-to-date actual performance. Not a huge amount of change from the last report that we took to the September governing body. And within the report then, there's some narrative around all of the individual areas where performance is not at the required standard. In terms of the cancer challenges that we have around 62-day treatment and for 31-day treatment for radiotherapy, I just want to mention that there are very, very small numbers of patients that we're talking about, and it is a part of a challenge that we have with the Royal Marsden Hospital, particularly around the radiotherapy challenge. For that performance, it is one patient who breached over a total of 15 different pathways. We have had one case of MRSA, and again, that is a zero-tolerance target or a zero-tolerance ambition that we have for MRSA. And each of those cases, there is a detailed, comprehensive review of that to identify whether there were any lapses of care. I will skip over the referral to treatment, as we've talked about that a little bit already. One issue which we talked about at the last meeting, which we still haven't had a satisfactory outcome and understanding yet, is the mixed-sex accommodation breaches at Imperial Hospital Trust. It has been a sustained challenge for them over the year to date, and I'm anticipating that for the November Quality Safety Performance Committee that we'll have some more detailed understanding as what those specific challenges are. You'll see then on section number 4, performance around the operating plan activity, and there are two areas where we are off plan, which I just wanted to draw the governing body's attention to. So the year-to-date August variation for consultant-led follow-up attendances, it has been running high for the year-to-date, but our performance in August is indicating that there is a slowdown of our overperformance, and it's reduced from 4.7% year-to-date in July down to 2.5%. And the second area then is around day cases, which is, again, it's about 5%, or just on the 5% mark for variation against plan. There has been, again, a marked reduction in our elective patients, and the comparison then, when we talk about April through to August, the overall variance is almost identical to what the plan was. The second part of the report, as I say, covers the more South West London picture, and I've summarised that in the table on the front page, but I'm happy at this stage to take any questions.
Thank you very much. Any questions or comments for Fergus? Stavrila.
Operating plan supporting activity. There has been a very marked reduction in total elective admissions, minus 37%. How can we explain that? Is that just seasonality? Because it's up to August, right?
So this essentially is the conversion rate from the referrals received to those requiring surgery. So it's clinically driven. It's that conversion from outpatients to procedures is not something that I think would be necessarily a seasonality issue.
Is it our ECI
so we can
procedures,
we'll do some more deep dive on what's the understanding the.
What's the issue? What are you concerned about?
well, we want obviously our patient, the public, to be assured that we're not putting any blocks into them having admissions for their elective problem.
So I think we can answer that one without doing a deep dive.
So absolutely, we want to assure that the conversion rate is from our excellent clinical colleagues in primary care, secondary care, who would only identify a patient for surgery if it was appropriate. My only thought in terms of a further nuance that would be the impact of the ECI. But again, that has been understood and talked about here and agreed as a very appropriate clinical strategy for patients to receive elective procedures. So I can happily take it away and look at more detail.
See if they are in categories of where the ECI policy has been adopted, isn't it? So it could be that the under the against plan, because it's against plan, isn't it?
Yeah. So the marker that will show if there is an issue would be the waiting list to surgery. If the waiting list to surgery has not changed, then it's just a change in the flow.
Yeah, this is quite significant, 36% less operations for one CCG. Or could it be maybe wrong data, or could it be collecting from one hospital?
Yes.
Or could it be, basic principle. Yeah. Or it could be because of the electronic referral system to the hospitals. We know that some hospitals, they run everything for 3 months. The old patients were follow-up appointments were moved for 3 or even 6 months, especially West Middlesex. So just wondered, did it also influence the operations? Did they postpone the elective surgery, for example? Is this the figure?
So we're not going to solve it here. We're going to take this out, and we will. It looks an odd number. Let's have a closer look. Any? Yeah.
If I may, I know we're going to go and have a look at the data in a bit more detail, but I just want to point out that ECIs are mainly day cases that we do, and the day case numbers have actually gone up a bit. So that would suggest that ECIs may not be the reason for the overall decline in.
Any other comments? I've sensed a tutorial on data management coming on, so that we're all looking at the things through the same lenses. If there are no other comments, quality and safety report? Is that?
So that's included within that report.
Okay, so if there's nothing else, I'm going to move us on to the Finance Committee report. And I think we must be getting to the end of our PDF, are we? No, not quite. Yarlini.
Thank you, Chair. And normally you ask me if I can do the two together, and I say no. And the time that you haven't asked me, I can actually do the two together. If I may. So the Finance Committee actually is the most recent Finance Committee that sat on the 30th of October and looked at the month 6 position, which is also included as the report that you have in front of you. So if I can do both together. You will know that we have a joint Finance Committee, and it was our 3rd combined Finance Committee at Kingston, and both Bob and David Knowles, his lay member counterpart at Kingston, take turns chairing that and do an excellent job. So thank you very much. We covered the month 6 position, but we also covered the QUIP position, which of course was highlighted in the risks that we've just seen. And we also had an introductory planning letter for 1920, which gave us an outline approach to planning and a whole host of proposals that might happen in terms of national tariff. But basically, it was just pushing us, I think, towards working towards a more system approach, working closer with our provider colleagues to understand the cost in the system and how we might best take that forward. It was a one-year planning guide before there's a sort of big bang that happens post-2021, I assume. But I think the thing that was slightly concerning was the timetable that was attached to it. So the planning guidance is expected in the middle of December. Normally we receive it on Christmas Eve, and our first plans, our first drafts have to go in on the 14th, our first operating plan needs to go in on 14th of January. So we discuss that in Finance Committee. We also looked at the QUIP report, which actually was showing an improvement. So we know there's a £16.1 million QUIP plan. We know that actually we had significant issues in terms of identifying 6.9 million of that at the beginning of the year. And what we've done is we've worked quite hard to look at stretching existing schemes and looking at non-recurrent ways of bridging that gap. And we are pleased to say that we're moving in the right direction, and we are overachieving by 1.8 million of the identified schemes, but that does leave us with a shortfall of 5 million, and hence that's why it's included within our BAF as a significant risk. In terms of the month 6 report, if I can just briefly take you through that. Again, the month 6 report is reporting to plan, recognising the significant risks that we have in the plan due to the unidentified QUIP that I've just mentioned. In month 6, we did see a slight improvement, a slowing down in the run rate for the acute position, and also an improvement in our prescribing and CHC spends. So what we are doing is obviously working each month at trying to de-risk the position. You can see the risk and mitigation slide on slide 13 within your pack. And we're working hard to de-risk the seasonality and work through improving our run rate in terms of QUIP, unidentified QUIP. And we are in regular conversation with both NHS England and South West London to see how we can have a system-wide, looking at our system-wide year-end position specifically, and also our forecast outturn for Richmond. So I'm happy to take any questions.
Thank you very much. So any questions for Yarlini on the Finance Committee summary and this month 6 report? Savrila, do you want to turn your light off?
Sorry
Yarlini?
to have to be the only one who always asks these difficult questions. I just put simply, I just wanted to understand how come we're overperforming in the acutes, as on slide 13, even though we've just seen we have less activity, we're referring less, there are few operations.
So the acute activity is made up of many things. It's not just elective activity, there's non-elective and outpatients as well. We are seeing a reduction in the run rate, so that is consistent with the messaging that you've been hearing. So our run rate was quite significant at the beginning of the month. So each month we were seeing a higher than expected variance. That is now tailing off. So we are seeing the improvements. I think, you know, there are issues in terms of the pressures that we are all seeing within some of the short-stay non-elective work that we have got, and also some one-off costs. So things like critical care, an increase in critical care that we wouldn't have anticipated. We have seen quite expensive costs for that. So there's a whole host of variables within that we need to look at.
Thank you. Any other questions or comments for Yarlini? Okay, I'm going to... Sorry.
So obviously, being in financial turnaround, so I think we ought to spend a little bit of time on the QIP, just about levels of confidence and how much more for this year do we think is achievable?
So we've identified 9.2 million of our QIP, and the stretch that we are seeing on that is an extra 1.8. I think, to be honest with you, it leaves 5 million of it in an extremely risky position. That being said, we have looked at our existing schemes that we've got to see if there's further transformational stretch that we can get on that. Now, if they deliver, that could be up to a further £1 million worth of savings. I think the key for us, though, Sarah, is to make sure that we absolutely have that transformational QIP ingrained so that we get our best position in for 18-19, but we are then in a very, very strong position for 19-20 moving forward.
Can I just ask a question on page 9, where it says learning difficulty? Is that not learning disability, or have I got that wrong?
Disabilities, yeah. Yeah.
Yeah, it's just to build a little bit on Yarlini's last point, because clearly we're in discussions with Southwest London, across Southwest London, and with NHSE about how we balance the Southwest London position, and clearly we've got pressures within Richmond that will need to be managed around that. Those discussions are ongoing. We are showing some improvement. I think what's becoming clear is there's a real risk we'll miss our financial plan this year. We didn't do that last year, so we might be in the position where we've got a better financial outturn this year, but we will still have missed our plan, which will have issues. The discussions we're having with NHSE and across Southwest London, just to really re-emphasise what Yarlini said, are about how we make sure we minimise this year's position or get the best position, and then how we really hit the floor running next year. So that transformational agenda that Yarlini's talked about is absolutely critical as we move forward, not just for ourselves, but also about how we work within Southwest London and how we get ourselves ready for next year, because next year's planning round is looking very challenging, as Yarlini said.
I do agree we need to concentrate on the QIP going forward, but again, I think we need to take a dose of realism, given that, as I said earlier, in what Fergus presented wasn't just elective admissions down. As you can see in the plan, total A&E attendances have gone down, non-elective admissions have gone down. So is this a sign that we are starting to work on our QIP plan? Would we expect these sort of numbers? And what more can we do, really?
So there is more. There is, of course, more to do, and I think there's a more system-wide approach to it. I think, you know, you're right in terms of where Richmond benchmarks. We benchmark quite well. We are in the lowest quartile in terms of our referrals, and we are seen to be, you know, in that most higher performing quartile for CCG. That being said, there are, you know, we are not the best. And I think in terms of the way that we have to move forward, we need to absolutely take the whole system-wide transformation. We can't be picking off certain areas. I think the difficulty about seeing Fergus's report is that that is the operating plan activity. And unfortunately, even though the operating plan activity does give an indication of the SLAM data, it doesn't give us the full picture. It gives us a snippet of from an activity perspective. Included within SLAM data, which is the data that we pay on, are all sorts of things that are not included. So excess bed days, maternity, critical care, all of those extra bits which we actually have to pay and which we'll see in the financial position are not included. So we're not comparing like with like. And what we have done outside of here, which we're very happy to share, is a bridge to show you the activity from an operating plan stance to a SLAM stance.
So I think it would be very helpful to see an activity to finance bridge. And I think that everyone struggles with that, to be honest. That's not, I'm not suggesting that's easy, but I think we ought to be able to show that, to have a real understanding of what's going on in our system. Otherwise, it becomes quite difficult to engage with the clinicians if we can't actually explain that in a way that they can see and understand.
Would it be sort of accurate to use a cliche that there are some green shoots here, or that we're actually beginning to see some evidence of change, given that we're running a, £250 million, £250 million organisation? It's a bit like turning an oil tanker, isn't it?
I think the engagement has really helped. I think we, in terms of looking at, so if we do it from a primary care perspective and the information that we've given to practices about their own activity, I think that's been really positive in terms of the information that we've shared, the peer reviews that we've had. And you can see the green shoots of the reduction in GP referrals from that. I also think that the kinesis implementation has been really beneficial, because and hopefully you can support this, because I think what it's done is it's meant that actually you've started forming relationships again with some of the secondary care consultants. So again, you have that link in, and I think that is, of course, really beneficial. I think the Outpatient Transformation Board last really well attended, and it was clinically led. It was really fantastic to see that joint piece of work with clinicians leading those groups and those pathways, which actually puts the patient first and makes sure that it's as smooth and as smooth as possible. So I think there are lots of green shoots in terms of that. The other thing, actually, if we've been really honest, is James has made reference to it. Next year's planning round is exceptionally difficult. And I think it's not just exceptionally difficult for Richmond, it is just exceptionally difficult. So I think the positive from that is that the behaviours are very different from individuals. So there is a true system working about, actually, if we've only got X amount of money between us, how can we best make it work? So I think the only thing that is stopping that is the time frame. So I think it's just trying to get as much done as possible in that time frame.
Okay, so we look forward to next month's report, and I'm going to move us forward to the end-of-life care strategy. And that's to you again, Julia.
I'm very pleased to bring to the board the end-of-life care strategy it is for Richmond and Kingston. This is a piece of work that's been undertaken in collaboration across the system with partners, with local people, to develop an end-of-life care strategy. It links into the work we're doing in South West London, and it is one of the themes in our local health and care plan in the age well, although recognise that end-of-life care can occur at various stages along the life cycle. And so this is an all-encompassing plan for both children and adults. The plan outlines the outcomes that we expect to achieve, and the most important one is about local people are supported to live well in the way they want to when they're approaching the end of the life and after, and then there is the support for bereavement. And it's all about good quality coordinated care, and where possible that actually is meeting their local and holistic preferences, but actually also is supportive of the family and relatives and others who have cared for them. So the plan's been through various iterations and has been through the clinical executive team and has come here really for approval by the board. There are priorities that are outlined in the slide deck, which we will come back and report to the board against. And again, these will all align with our commissioning and local health and care plan. So I'm going to assume that you've read the plan, and I'll take any questions that it's here to the board for approval, please.
Okay, so it's a very thorough and comprehensive document. Has anybody got any questions for Julia? Yes, Sue.
Yes, very comprehensive plan. Given the vulnerability de facto of people and also the families in the latter stages of life, can you just tell us a little bit more of how we've managed to engage with those groups on what is a very difficult question often for people to talk through? Thank you.
There has been a wide range of conversations with the voluntary sector and some individuals who've been more than prepared to, particularly families and relatives, to contribute. But I think it's one of those areas where we perhaps need to do more and have more conversations. It's not something that we do well. So I think there is still more to do, but there have been key people who have contributed to this from our local families and local people, and, you know, thank you to them for their support in helping to produce this report.
I think it's a very good strategy. I think it's a good idea to do it together with Kingston, and also like the idea of the dashboard that will monitor the outcomes of this strategy.
Sarah?
Can I ask about the compassionate care section? Because I think that's a great, you know, that's what we all strive for. And is how are we actually proposing that we take that forward? Because, I mean, we would all hopefully want that to be happening, but it's much more of a cultural change than it is it talks about some training, but I just wondered what we thought was going to happen in order to make that a reality for people.
So I think we're sort of at the early stages. What we have done is we've commissioned various training using the compassionate care approach, and we've worked very closely with Princess Alice Hospice supporting a lot of that work. And one of our local GP leads has compassionate care is very much part of, you know, runs through her, and so from that point of view she's been an advocate. I still think it's early days, Sarah, in terms of actually saying we will be fully compassionate community compliant, if that's the right word, but it is work that we are doing collectively across the agencies, and we've been putting training and development in with local people and practitioners.
So I think this is a fantastic ambition. I think for us it's how will we be able to deliver some of these things that are actually less tangible. So, you know, we can count the number of people that die in hospital in comparison to the number of people that maybe die in their place of choice. The issue is, you know, was that, you know, it's very difficult to say, was that a good death? You know, was it something that they said that they and the family was what they wanted and in the way in which they wanted it, and were they supported in the right way through that is less easy to measure. So I just think we might need to think about how do we measure the less tangible parts of the plan going forward, because those are just as important as the kind of numbers.
I've got Kate and then Tony.
So, I mean, reading the bit about your sort of compassionate care and making communities caring, I think, you know, that for me feels like it fits into sort of not quite social prescribing, but looking around, you know, how communities support people. So, I mean, it was quite interesting because when we were talking about social prescribing, we talked about groups in the community that we needed to engage with. And one of the groups were things like religious groups, which maybe we don't engage with well. And I think that that's an area that's quite helpful. I think, you know, I've seen examples in my time as a GP about compassionate communities, and it's actually really very powerful. And I think they seem to be quite small things. They don't cost anything, but actually what they do is they can help people look back over the years of, you know, having a good death. You know, it's small things like, you know, I had a family where there were several children and one of the parents was dying, and the local community rallied around via the school to deliver meals to the family every evening. They got a hot meal delivered to the front door at a certain time. And it's those sort of quite small things. But as Sarah says, it's how do you manage it and how do you rally your communities to be able to do those things, and how can we try and support and promote it, and, you know, encourage people to be good neighbours, good members of their community. And I'm not sure of the answer, but it feels sort of like it fits in with the social prescribing element of communities supporting everyone in their community.
I know, I was wondering if we asked the steering group to think about that and actually how they would want to measure it and what does it mean, what would it mean for them, and actually ask them to come back and just describe that, because they will have a view of what it means for them as a group and how they would want to promote it, but also how they would want to measure that. So maybe we could ask them to come back on that specific piece.
Again. Yes, I think Healthwatch would like to see this. We did have a member on the working group, and she wasn't aware that there was a final draft had come out, and was quite surprised. It could be, she said, that she missed a meeting or a piece of paper or something. But Healthwatch would like to know more about this final draft and to be able to publicise parts of it. But if there is going to be a group looking at what the impact is on patients, particularly in Richmond, maybe that's the better time for having something that goes out, some sort of summary, so that people know what to expect. But also people, because not everybody's going to wait until they're approached sort of a few weeks before they die. A lot of people will look at these things in the later years of their life or whatever, not just right at the end.
So perhaps I can suggest that I ask Jackie, who is leading this piece of work, to have a conversation with you, Kathy, about coming and doing a presentation to Healthwatch, and then as part of that, discuss what we then, you can support and what next steps we can take around that in terms of information.
I just wanted to note that on the Appendix D, on the indicators against the strategy, on the equality section, there's a very distinct focus on looking at dementia and cancer, but I just wondered in terms of overall inequalities, whether there's potential at looking at particularly deprived people who are in the most deprived areas, because I think in relatively affluent boroughs such as Richmond, there's always a potential for inequalities to be masked. And I think with the kind of data you have, you can definitely look at whether people from those most deprived communities are having the same sort of equality in terms of place of choice of death.
Yes, I'll take that back. Thank you.
Any other comments? Sue?
Just a final add-on, really, in terms of not consultation, but engaging. I mean, we can certainly, I don't think this has been to our community involvement group, which would be quite useful, because I have a lot of agencies on who deal with communities that would, relevant communities. So I would suggest that that might be a step, as well as the liaison proposed with Healthwatch, or maybe bring that together.
Can I suggest then what I do is I take it back to the steering group that we having, if we are approving the plan today, that we then come up with a plan of communications and engagement around this, that we approve that and then have a range of conversations and discussions with a whole range of groups.
On how to, I think that would be, that would be helpful for both.
Thank you.
Sides.
No, that would be helpful. Thank you very much.
Yes, Cathy.
It was just on page 36 under the March 2019. It was just around the languaging, really. It was, so if you look at point 3, it says, have supported clinicians to feel more confident. Further down, support care home staff and GPs. But this is everybody's business. So how do we make sure that we're inclusive in our language as to who we are, making sure is aware and enabled to have a conversation and to engage in that planning for that person's end of life?
Yeah. I assume there are reasons as to why, as a multi-agency steering group of clinicians, professionals, doctors, nurses, local hospice, clinical nurse specialists, particularly identified and use that language. I can take that back. But I think it is, the intention is it is all inclusive. But there are particular issues, I think, around care home staff, and there may also, and the links therefore with GPs who have responsibility for managing, for providing the primary care for people in care homes, and care homes feeling supported. And then there is the other piece about all clinicians being able to have those conversations about end-of-life care.
I suppose that's my point, really, about kind of making sure that we're clear about who we are. Because clinician, for a lot of people, means medical clinician. And I think we just need to be clear about who we're talking about. I think it's interchangeable. That's just my commentary.
Okay, so this is brought to us for ratification. I've heard a few helpful comments back. Are we happy to approve this as a governing body? Okay, we'll take that as unanimously approved, unless there's... Okay, we'll take that as unanimously approved. We've got a number of minutes for information. So we've got minutes from the Primary Care Commissioning Committee and the South West London Decision-Making Committee that I alluded to earlier. We'll take those as read, unless anybody's got any burning feedback or issues. Okay, I'm going to move us on to 4.2 then, our Kingston and Richmond CCG risk management policy. I'm just taking that.
It's really for it's for noting, isn't it?
Okay.
Information. It was approved by the executive management team at the last meeting.
Okay, so we'll note that as well, unless anybody's got any comments, which Tanya will take. Okay, I will remind colleagues of the next meeting, which is on the 8th of January. So happy Christmas, happy New Year, and we will see you back in 2019. I said I would run to time, and I've virtually done so. So has anybody got any other business before I move us on to public questions? No. So members of the public present are invited to ask questions of the CCG governing body relating to the business being conducted. Priority will be given to written questions that have been received in advance. Did we have any written questions, Joe? I think Wendy was about to for next year, but if I don't, I'll see you next January.